on this computer. All right, welcome to the Surgical Informatics lecture series. This is a monthly lecture series in the lab that we're starting, in which we have notable people from the informatics world teach our lab about important concepts and how they can be applied to research and surgery. So just for a bit of background, also I'm Jason Marwaha. I'm a postdoc in the Surgical Informatics Lab, which is a lab based jointly at Beth Deaconess Medical Center, Department of Surgery, and also the Harvard Medical School Department of Biomedical Informatics in Boston, Massachusetts. And the lab is run by Dr. Gabriel Brat, who is a trauma surgeon and an intensivist and an informaticist at Beth Israel and Harvard Medical School. And our lab studies really all things related to informatics and data science and surgery, from intraoperative computer vision work to building and deploying surgical prediction models and many, many other things. And so for today's lecture, I'm very excited to introduce Dr. Harold Lehmann, who's the creator of the Informatics Stack framework, among many, many other things. Dr. Lehmann's a professor of health sciences, health sciences, informatics, and pediatrics at Johns Hopkins University School of Medicine. He also holds appointments in health policy and management and in international health at the Johns Hopkins Bloomberg School of Public Health, and also serves as the Director of Research and Training for the Division of Health Sciences Informatics. One of his many contributions to the field, as I mentioned, is the Informatics Stack, which is a widely used framework in many informatics curricula, including ours at Harvard DBMI, for organizing how data is stored and transmitted and retrieved and used at all levels in large healthcare organizations. And so he'll be talking about his framework and how it relates to surgery and surgical data science. And and also of note, I also learned today that he also teaches a Coursera course on this framework that has been taken so far by over 21,000 people. So with that, I'll pass off the mic to Dr. Lehmann. Thanks so much for joining our lab today.
My pleasure. It's great to be here. A couple of things. I'm not going to be in presentation mode, both because the machine doesn't understand how to do it, and I like to be able to zoom back and forth. Since the division has changed its name to the Division of Biomedical Informatics and Data Science, now the Department of Medicine, and I've stepped back from leadership roles so I can devote more time to Expert Coronet and 3C and some other issues. But I do like to be interactive. I know that we're recording, but I also want to respond to folks. But let's get underway. What we'll be talking about is a framework. I don't think we'll be talking about any technology. There won't be one 2x2 table or ROC curve or Bayesian equation, as much as it pains me not to show those. What I'm showing is, what I'll be talking about is a framework that I use both as a basis of an 8-week course. So I'm giving you in 1 hour in eight weeks, so we may be going quickly. The goal is to really change your brain. And I've had students, I had a student call me up like 7 in the morning a few months ago and said, "Did I wake you up?" And I couldn't say yes, but he said, "I just want you to know I use the stack every single day." And I kind of get this. So in statistics, there's something called the jackknife, it's called the jackknife because it's supposed to be universally useful. And so that's how I feel about the stack. So we're going to talk about why yet another framework, the millions of frameworks in informatics. Talk about the problems that Stack is designed to solve. First, talk about the 2 levels of the stack. So if you learn nothing else, you're going to learn 2 words. And then the 8 levels would be nice if you can get to that. So the goal of this framework, so we use frameworks for many things in informatics. It's a way of organizing information so that if you collect data in the implementation science or safety, have you covered the waterfront, right? That's why you have a framework. And so the same thing over here is when you're called into an informatics problem, can you make sense of what you're hearing? Can you you identify what you have in front of you? Can you define what's missing, right? And have you your ducks in a row? And we'll be talking about the two levels of the stack. It's hysterical. You walk in, you say, oh, you're not talking about this, the what you want to accomplish. And everybody says, oh, you're a genius. Say, no, I just know two words, what and how. I'm a big genius. Because I'm reducing everything to two words, it's not a lot of, I'm reducing the cognitive workload, and again, identify what's missing. So what should the stack help you with? So do I have an information problem, or is it something else? If it's not an information problem, you should be talking about, I don't know what. So if it's a food problem, a surgical problem, a management problem, well, the management has information to it. It's not. But if I have an information problem, now what do I do? How do I define the problem? And if I have a solution, does it solve the problem? Now, any of you who are involved, I'm going to say data science or predictive analytics, everybody's coming at you with AI and bright, shiny objects. And the question is it a problem and is it a solution in search of a problem, or is it solving a problem? And for a lot of people in administrative roles where people are coming with them all the time with, oh, we should do this, we should do that, you want to have some basis to say yes or no. And if you have a problem, you want to have some basis to judge, well, is this a real solution? And again, what's missing? So I just happened upon this list of items. Jason sent them to me. And so I'll try to come back to these. So computer vision models. So I think, Jordan, that's what you're working with. So this sounds pretty technical. A vision model, that's pretty technical, but wait, live surgery, that's people, interoperative guidance, now we're getting into the domain, and now we're dealing with people. So it's exactly this mix of technology and people that informatics is all about, and that a socio-technical framework of informatics should help you. So, Singh and Siddiq have talked about this notion of a socio-technical approach to informatics, and in many ways, the stack is a kind of a light but implementable version of that. If you're talking about clinical risk prediction, risk sounds very technical, right? It's coming up with a probability, but it's a prediction in a clinical context. Now what happens? And I think you all know that if you calculate the wrong type of number at the wrong time, it's useless, right? So getting the fit between the technology and the use is high. And so we have the perspectives, software engineering on the one hand, which is kind of the technical implementation science, the clinical on the other hand. So you see, I'm already in each one of these examples, there's a socio component and a technical component, or what I call the what and the how, which we'll get to.
Dr. Lehmann, I just want to briefly interrupt. If you want me to share your slides on your behalf, I'm happy to, because I have them pulled up here. Or if it is working on your end, then
I'm happy to advance them, but feel free to share them with folks on the call.
Perfect.
Because I may need to navigate. That's why. Surgeons understand about needing to feel in control, right? Right, guys. Right. So, all right. So what's an information problem? So anything dealing with data, information, or knowledge, which sounds pretty broad, right? And I won't push you, but remember, data is the factoid, 98.6. Information is that it's the temperature, and knowledge is that it's normal, or don't do anything. Well, wisdom generally is don't do anything. So sometimes people have wisdom. But things that are not really informatics problems, manufacturing of gizmos, let's say, it's not really an informatics problem. Talking with a patient or client, one could, there's a borderline between where this becomes informatics or not. I threw in dating for fun, although one could use decision analysis to decide whether to continue a relationship and how to continue it, but I won't go there either. So let me just skip to here. So if I have a potential solution, does it solve the problem? And this is going to be coming up over and over again. The problem, and these are my fingers. It took me a while to get the fingers aligned. But what you want to accomplish and how you're going to accomplish it that's it. And anybody in the technical field knows this, right? So somebody, I'll make a pseudo-surgical thing, but somebody comes with a bellyache, before you operate, you want to be sure that the operation, the very technical thing that you need to do, is going to solve the problem above the line. And when we talk about a surgical candidate, what we're talking about is somebody for whom we have a high likelihood that the technical solution is going to solve the problem. Because if it doesn't, you'll have a very unhappy patient, and you're putting a patient at risk, which you don't want to do. So we all understand very well this notion of the coherence between what you want to accomplish and how to accomplish it. And it's hysterical how just that discipline, what versus how, can help cut through so much crap when it comes to talking about IT and informatics. So I like bringing up in public health. Nobody knows what a p-value is or confidence interval is, because it's a solution to the wrong question. Everybody wants to know, what's the probability that the hypothesis is true? And the statisticians refuse to let you say that, right? What they give you is, what's the probability that if you were to do the experiment 100 times, you get, everybody, that's a classic example of this. I want to know how likely the hypothesis is. Oh, I'll give you something like it, but it's not answering the question. So we all forget it, all right? So that's a classic example. And I also bring it up in this context because in many ways, medical folks have outsourced thinking to the schools of public health, or they've outsourced epistemology. How do you know what you know? So you kill yourselves to do all the work, you kill yourself to do all the data, then you hand it off to the data scientists and statisticians to tell you what the data say, right? And by saying, no, this is the questions I want the data to answer. If you can't answer it with what I'm giving you, I want somebody else. That's the type of discipline I want to advocate. And then what's missing? So there are going to be layers to the stack. This one's a stack. And if you can say, where do things belong? It really helps organize. So this last weekend, the American College of Medical Informatics had a 3-day conference on the public health information infrastructure. And people from all over the place were talking, and we all agreed that the stack is the way to organize at least the concepts that everybody was talking about, so we know where we are, and then we can start arguing. I'll say a little bit more about that as we go along. So this is the core of the talk, the 2-layer stack, because I think everybody can leave knowing 2 things. So there you go. So basically, what you want to accomplish and how you want to accomplish it. That's it.
I apologize. I'm just going to ask one more time, just because. So I'm looking at these slides and they're fantastic. I just want to be clear. As of right now, no one can see the slides on the video. If you prefer not to do that, that's fine. I just want
somebody should say, Dr. Lehmann, that's very nice, but you haven't shared your slides yet.
Okay.
Thank you. So let me get that. Thank you. So that's so embarrassing. All right. So but I've shown you my hands. So now so at least that's really the only graphic that you're missing. But so do I have an information problem? How do I define it? Solution, what's missing? So now we're going to go to the 2-layer stack. Thank you so much. All right. So what to accomplish and how to accomplish it? I've never done Zoom before, so really so. All right, that was a joke. Okay, and you are allowed to laugh, but not if it's.
We laugh. We just put ourselves on silent.
I don't get no respect. So you've all seen, so now you've all seen pictures like this, right? You've all seen the learning health system, right? And so this is what you want to accomplish. This says nothing about how, right? We want to implement, if you want to get the data, I don't know how to, I don't know how to implement it. I don't know how to evaluate. What this adjusted, what does that mean? Disseminate, I don't know, I guess some technology is required. So this is a classic example of what you want to accomplish. It doesn't tell you anything about how to do it. And even more, you're going to see me calling this the business cycle or the business process for this particular problem. Okay. Here's another one. This is the developing insights. This is now counterclockwise. I don't know why. Here's a little model we had for dealing with public health. None of this tells you how to do any of this, but it's telling you kind of what you need to do, what the basic steps are, right? So that's, as I said, this you can discuss. So what you want to accomplish and how you'll accomplish it, the how will involve analytics, knowledge generation, research, implementing. This is the afferent side of informatics. This is the efferent side of informatics, collecting information and analyzing it, putting it into practice. And there's a paper by Philip Payne and others called afferent and efferent informatics, although I was using the term before they wrote the paper. So here's just a little example. Somebody comes to me and says, I need a database to track TB cases, to be on the lookout for multiply resistant TB. So I think you can all see, do you all see that this is mixing how and what, right? So tracking TB sounds like a what? Looking out for multiple resistance is a what? Database, what the heck? Why the heck is a doctor using the language database? Right? And the problem with that is when the programmer hears you say, I need a database, they say, oh, they need a relational database, and not realizing you have no idea what you're talking about. You want a data repository that has certain features, but you want to sound like hip, right? Because you've read Wired magazine, and so you want to sound like you know what you're talking about. So, oh, I want to know SQL, because all my friends have one. I want one too. All right. So, and so here, this is all about what, and so you can see how that works. So there's the how word, etc. So I just went to that example. So multiply resistant TB is a kind of interesting. Here I put it under how. This is one of those in-between concepts that somebody in the outside world, they can understand the notion of TB, but they may not understand that multiply resistant is an important thing. So in many ways, if you're a physician, you're a how person to a patient, but to the informatics guy, you're a what person. So one person's what can be another person's how. One person's how could be another word's what. So I don't want to be strict about this, but I want you to be thinking, what is my what and what is my how? When you go talking to an IT person, when you go talking to the data scientist, when you go talking to the informatician, you're in charge of what? And you're in charge of what I want the system to accomplish. And if you can't accomplish it, I want somebody else. Don't tell me that it can't. Or if it really, really can't, then I'm going to have to change the what. But let's do it proactively and consciously, mindfully, to use a phrase. Don't let the software force you to do something you don't want to do. That's the worst of the worst. I can't do it because the software doesn't let me. Tracking TB, again, the public may not realize that patients might need, they may not know about case notification, although now everybody knows about case notification, but certainly a public health practitioner knows this. But so this is their what to the database how. And by the way, a lot of people in public health don't really know databases, and they don't teach informatics in schools of public health. Epidemiologists don't know informatics. They don't understand the complexity of EHR data and how to turn an EHR datum into a statistical variable. That process, if we have time, I'll show you a little insight about that as well. The statistician now is above the line. They know what they want to accomplish. They want a variable. They have no idea how to get a variable out of an EHR. The whole concept sets and codes and all this nonsense and all the technology of real world evidence, a lot of them don't get. So to push, so here's the what. I want to minimize mortality within patients due to TB. I want to minimize spread between patients. So it can take a while to take what the request came to and to realize what the goals, what the whats are. When I ask folks, this decision support tool, what's its purpose? They tell me to alert the physician. No. What's its purpose? To get them to say, I want to minimize death due to drug-drug interactions can actually take 10 minutes. To get people to understand what the real purpose of the intervention is. And then if I say, what's the probability, this is where we go to thresholds that we were talking about before we started recording. If I say, what probability is driving the decision, they look at me like I'm nuts. And the truth of the matter is, right, it's some probability, why do you operate on somebody with appendicitis? Well, because it can, give them peritonitis and kill them. That's a pretty big probability. You don't really, it's not the appendicitis. Well, you can tell me if I'm wrong. It's not so much the appendicitis that you're treating, it's the probability of dying from peritonitis. Is that, I'm asking you clinically, would that be fair to say? Is that why you operate from appendicitis?
Absolutely.
Yes.
Right? But if I ask you, what's the driving probability, it probably would take you many minutes to articulate that. And if I ask you, why are we doing surveillance of, and what when we do surveillance, we're looking for a probability of an outbreak or a probability of some horrible disease, which does not exist, and it doesn't exist. It's like a virtual, unobserved thing. Future peritonitis doesn't exist either. It's in your head. You're treating something that's in your head, even though the patient is at risk. So this is a complication that we don't teach about when we simply teach statistics and all this stuff, but it's it is the basic science of decision making. And no, here's the decision. I want to minimize mortality. I want to minimize spread between patients. So I feel strongly that informatics is very, very tied to decision making. Not everybody feels that strongly, but there you go. So I mean, here's language that that we see in that come up all the time, and this is an example where here's this word salad that people throw you. Where do you put these words? How do you organize it? And so at the minimum, there's what concepts and how concepts. That's all. So that's step one. Is it a what or is it a how? And I tell you, when people come to me with an informatics problem, like 90% of the time is, what's the what and what's the how? And are they confused in their head? Because if they're confused, that's a signal that you're going to be run away screaming, or if it's your dean getting how and what confused, you have an ethical dilemma, don't you? But helping people separate out the what from the how is, number one, it saves you. It's a survival skill in informatics, but also helps clarify a lot of stuff, because the statistician and the programmer should not be answering these questions. The doctor should not necessarily be answering these questions. There'll be obviously you want the clinician to tell you what the knowledge is, but not how to represent the knowledge. That's nuts. All right. So now we get to the 8-layer stack. And so we're going to do this in 2 sets, 4 and 4. So the first set of 4 is going to be what's above, there's going to be the what, and the second 4 is going to be the how. And the source for, now, a couple of things. I call it a stack, but it's really a Russian doll. You'll see how each layer contains everything inside of it. I actually once I found a CT scan of a Russian doll. It looks just like this, but I didn't have the rights for it, so I can't use it. But the idea, the reason this came out of the desire, if we're informatics and informatics about knowledge, and teaching informatics is conveying knowledge, I should use informatics concepts to talk about informatics, right? It's classic, like yet another compiler, or yet another so-and-so. So the idea is that there are layers. So the top layer is the world that you're in. So you can say, are you guys in the world of clinical surgery? Are you in the world of academic surgery? Are you in the world of medical education? Surgery? It's your choice. I have no, but which world are you in? Now, obviously, you're in multiple worlds, but for the information problem at hand, you want to think about which world are we in, right? And then, so the computer, so if you're computer vision for education, sounds like something between professional education. It's going to have a lot of regulation around it, right? Because, and maybe there's going to be income is going to be involved because you're judging surgical skill. And then if I'm bad, then I'm going to lose my certification. So there's a lot of governance and all that sort of stuff that could be around it. If I'm looking at clinical risk prediction, sounds like I'm in the world of clinical care. Maybe academic clinical care, but some sort of clinical care. Then there's the organization. Obviously, for each one of those worlds, there are many organizations in that world. So in the world of surgical education, they're the professional societies, the BIDMC, then they're the gizmo, they're the patent offices, the vendors, creating all these things. So there are multiple organizations. And then within an organization, there are multiple roles. And each one of you plays multiple roles, right? And each role has multiple people playing that role. So certainly clinician, there are many, every clinician is a clinician and a teacher and a learner and an administrator and a population health manager. That's a clinician. Then you throw in scientists, et cetera, et cetera. And obviously there are many clinicians, there are many administrators, there are many learners, learning teachers. So it's a many-to-many relationship. Then we get into goals and business processes, some of those cycles that I showed you. Then finally, the workflow and the data flow, that is how these things get done. So, so these are some examples of that. So you can see here are different. So this is a clinical environment. Here's a public health environment, research, for-profit organizations. So there's a lot to keep track of. You don't necessarily do all of it. You don't have to be compulsive to get everything, every jot and tittle correct. The main point here is, okay, here's an organization, I'll put it at that level. Don't get the organization and the role confused. Don't get the workflow and the world confused. The world goes in the world area, governance goes up there. So governance goes somewhere between world and organization roles, right? And then, labor practices will go somewhere around here. And, policies will kind of go over here. Procedures will go over here. So you get a sense of where things go. It's really hard for me to do multiple choice questions because there's no wrong answer really, but there's the whole idea is to get the flavor of where things go. Again, for your personal survival. So going back to the words we had before, the domains now are something like worlds, business case goes with over here, use case scenario. These all go into kind of what you want to accomplish. Requirements tend to go into, again, what you want to accomplish. The actors are the people, flow of events, workflow, data flow from the previous slide. That left-hand side can map onto here. Any questions so far? Have you already thought about, oh, I was getting this other thing confused. This helps me layer it out. Does any of that come to mind? Yeah, I say Gabriel. Okay. Then we get the lower level of the stack. This is now more the how. Now we start getting into information systems, the EHRs, public health suffers because there is no platform for public health. We spent 30, 40 years developing a platform for clinical care called the EHR, which everybody wants to throw a shoe at the window. But, the reason why we want to throw a shoe at the screen is that the computer is part of our work team. But programs basically are individuals with personality disorders. They're self-centered. You have to give it to them just the way they want it. It sounds actually like some people I know, but anyway, and you know that when you have somebody with a personality disorder on your work team, it's really difficult. And now for the last 10 years, we've insisted that every work team has participating with it, a participant with a personality disorder who's really narcissistic and self-centered. And that I have a mild hypothesis that that's been making people miserable. At this level, I do have two levels, because if you take any computer science, basic computer science, they talk about data structures and algorithms. So I want to separate the nouns from the verbs of computer science. I already told you about data, information, and knowledge. Models is a special sort of a thing. I'll add in evidence. Evidence is what connects data to knowledge. And a lot of computer people don't know what to do with evidence. They know about data, they know about information, they know about knowledge, but they don't understand really how data becomes knowledge. And that's evidence, and that's the rules of statistics and epistemology and the research design and all that sort of stuff. And it's been a tricky animal to deal with for the last while. Then the analytics and the algorithms, the decision support, those are all how you use the data, either to learn or either afferent to learn or efferent to put into place. And then finally get to the technology, which is certainly the technology has enabled a lot of stuff that has not happened before. Without the smartphone, you can't have engaged patients the way they're engaged today. On the other hand, you can see that the technology is only a part of the entire picture. So when you get somebody going on and on about their technology, they're missing the point. And even if it's a handheld ultrasound device, the question is not just how good the ultrasound device is, but how does it perform in the environment? How does it perform not only diagnostically, but in how does it affect the practice of medicine? So I always ask the students to say, I want you to envision this technology. How will it change medicine? How will it change the practice of medicine? So I call it informatics applied science fiction, because you have to create a world that doesn't exist and you have to live there. You have to try to figure out, what does it mean to live in this world? Most of us think of technology as a horseless carriage. It's really hard to get into the automobile. And we're still mostly at horseless carriage stage. We're using the old metaphor to describe the new technology. So the old EHRs almost always had a tab-based metaphor, right? They are the little, because they were horseless carriages. They were emulating file folders. It's taken 20 years, but now we finally can make EHRs that look like websites, because people now, they know what a website is. So Athena and everybody else. But we still like the tabs. I want my horse and buggy. So the information system can be So the information system is kind of complicated because it's a system of systems. So I'll give you an example. The OR management system, is that a module of a larger system, or is it a system of its own? And there's no wrong answer. It's part of the larger system because it communicates with the EHR. Everybody knows what's going on, but it's its own thing because nobody else really cares about the beds and the rooms and the turnover and all that sort of stuff. That's only within the surgical suite. And it too has a bunch of systems that it supplies it, the supplies and the labor and the patient management. So it's called system of systems, which, by the way, whenever you hear system of systems, you have to think about a complex adaptive system. This phrase, I used to this phrase. And a complex adaptive system is where nobody knows what the hell is going on, basically, right? And you get emergent behavior and a lot of nonlinear results. So a small change in input, you give a big change in output, and sometimes a big change in input gives not much change at all. So a medical organization, a healthcare organization, is definitely a complex adaptive system, and the information system that underlies it ends up having also emergent properties and mirroring the complexity of the system above it. So the system of systems, we talked about we talked about this, so, by the way, security. Well, I'll say, I'll say something about that coming down. So again, all this language technical use case transactions is either the data flow with the information system. Above we had the high level tasks that had to be performed. The information system has the much lower level tasks that need to be performed. And so forth. So I keep on talking. I always envision a line that separates the top of the stack from the bottom of the stack, and we could be, the line really is kind of over here, because one could argue that the workflow is how you accomplish this. I don't want to go nuts enough, but basically the way. So you'll hear me say, is it above the line concern or is it below the line concern? What versus how? And everybody, all my graduates, they know this. If I say above the line, they know exactly what we're talking about. It becomes a very useful shorthand to say, where are we? But that's it, above the line, below the line. That's really what the take-home message from this talk. So now the question is, if I have an informatics problem, can it be represented by the stack? And is data information knowledge key? If data information knowledge is not key to the problem, then it's probably not an information problem. It's another sort of a problem, which means, by the way, that all statistics are informatics solutions. So when I complain about p-values and confidence intervals not addressing the problem, I'm saying it's a bad informatics solution. All right. Now, I started out 30 years ago as a nut Bayesian. It took me a while to realize the value of things like p-values and confidence intervals for population health and so on and so forth. But realizing that they are hacks, they are a certain type of a hack to give the appearance of objectivity, because you really don't want the drug companies giving you their prior probabilities. This is basically what it boils down to, as somebody from the FDA once pointed out to me. So do I have an information problem? Can it be represented in the stack? If I have an information problem, how do I define it? So I should define it above the line and maybe below the line as well. If I have a solution to solve a problem, again, is the solution down here coherent with the stuff up here? If you can't figure out what's going on up here, you don't got down here. I'm an associate editor in JAMIA. So every week I'm looking at about 10 articles, and half of them are predictive models. And if I smell that it's a model that's a solution in search of a problem, I reject it. If they can't articulate the problem, if they haven't demonstrated conversations with the domain people and how those conversations have defined the requirements for the below the line model, I don't want to hear about it. Waste of time. And what's missing? So that's the fun part. So that there, unfortunately, you have to pay attention. Then, you know, after you listen for a while, you say, well, now what's missing for what I'm hearing about? So they go on about the technology, but you never really heard what their goals are. I better push them on their goals. And that's where you sound like a real genius. They say, and somebody was telling me, she's been like, yeah, you hear people go on about NLP, natural language processing. Ooh, NLP. Okay, unstructured data and analytics. Very nice. Now, for what purpose? And then they get, what do you mean what purpose? Well, why are you killing yourself? Right? I don't know. It sounds like fun. Not a good answer. For a student, maybe okay, but not for you guys. You don't have the time for fun. So now you see when I make my I think you have a better sense of how you need things to line up. Now the truth of the matter is it's not one-to-one, right? It's never really one-to-one, right? But you should be able to say that this concern is managed by these fingers. So if somebody comes to me and says, I'm worried about making the wrong answer, that's a regret, and they want to use decision analysis. It turns out in a decision model, you really don't want to model the regret. So you say, I hear you. I'm not going to put it into the model, but I'm going to address it. Or I want to predict such and such, and I say, look, I really can't do it exactly. I'm going to tell you what I can predict, but I'm still going to address your concern. But I'm not going to tell you that you have to use my prediction model in the way that I'm telling you. I still have to cater to what you requested me to do. So it sounds a little, so the weight is more. So first of all, getting it. So the as is, this idea is that you walk in and people give you stuff all over the place. So sometimes just organizing the to-be state in this coherent story can be very liberating. And as an example, in public health, they are funded in silos. So they have databases in silos and procedures in silos and processes in silos and staff in silos. It was a big realization that they can horizontalize the technology and the data information knowledge and information system, and then they can get each function on top of these horizontals. That's called data modernization, and we're hoping it's a big discovery in the CDC. A lot of people in public health have been trying to do it, but again, the CDC is run by epidemiologists, so they really haven't, and they're funded by government policymakers who don't understand these ideas. Relationship between two agents, right? So we talk about interoperability a lot, right? And interoperability sounds like getting data from here to here. But the real story is that you can't get data going across from one place to another at any level unless it goes across at every level. And this is a hard lesson to learn. Yes, I have to have a data standard. I have to have TCP/IP. I got to use the internet. But wait a minute, what's the envelope that I'm going to stuff the data into? Is it HL7 message? Is it a FHIR message? Is it proprietary? Yeah. And then who am I talking about? Do we have a master patient index? How do I know who's who, right? And then we need to have privacy standards and functional standards. We need to have, we have to have contracts and regulations. You can't get data going from point A to point B unless you have all of this. And I was brought into a program of home visiting researchers. These are people who research about home visiting programs. These folks are the furthest you can get from, data science informatics. They're all statisticians and epidemiologists and researchers, and people who care about children and all that. And they love this model, and we created a whole information model for their whole domain, growing off of this paradigm. The other part of the paradigm: privacy, confidentiality, and security. So there you go. Privacy tends to be at the top of the stack. These are relationships. These are promises that one person makes to another person, or an entity makes to another entity. Whereas security is using technology to protect the data. And confidentiality really is about the policies and procedures, how human beings get access to the data. So this helps to help, again, locate. I wish there was a word for these three things together, but what the heck. But that helps me. Governance, I'm not as well. Anna Orlova was a colleague of mine. We worked together in this. I don't have this down pat as she does, but we feel that governance issues play a role at each level. And I should point out, I don't have it here. I should point out that at each level, there are, and I left this out, I apologize, it's in the appendix, I think, that there are common things to each level. Every level is worried about money. There's staffing at each level. There are laws at each level. There are ethical issues at each level. But they tend to be particular. So the ethical concerns about technology is a little bit different about the ethical concerns of the workflow. I don't want to go into detail. It's not as well worked out. But again, it helps you focus, where are we? But I do want to point out, and the students always complain that I don't talk about money a lot. Oh, the other thing that this is not about how to develop software. This is nothing about the process of developing software. It is about getting the requirements. It is about making sure that the solution meets the requirements, and therefore, in terms of evaluation and science, there are different approaches at each level of the stack. Let me just, I know we're kind of getting, there you go. So health services research implementation, well, health services research tends to be up here. Implementation science tends to be around here. Domain is over here. Management science is definitely at the organization, also at the workflow level. Then here's where you get your anthropology and the others. Software engineering, philosophy for crying out loud, as well as data science and computer science and engineering. So, and by the way, there are quantitative skills or quantitative methods and qualitative methods that are appropriate at each level in a different way. So also the methods used, but also shows that if you're doing informatics research, you have to have some familiarity with all these areas. And this shows you why. So you'll very often see a picture that shows all these different domains pointing to informatics, but they don't tell you why. So I'm telling you why they're important. And there's each one speaks. Each domain, each methodology speaks to a different level of the stack. Yeah. So I said. So summary: the informatics separates what from how, above the line and below the line. Data layers can help you do all this stuff. Go from as is to be. It doesn't give you the two part, doesn't tell you how to do it, but at least you can represent as is and you can represent to be. So I look at it as anatomy. It's not physiology, it's anatomy. Identify gaps, interoperability. So it's not a bad little framework for thinking about informatics, all done in 57 minutes. So I know we're over. But if anybody does have questions, I'm happy to, if you have any questions you want to ask.
Why don't we stop the recording and allow anybody to give